I would like to thank a lot Professor Wilfried Mullens that today is here and will speak about volume overload in acute decompensated heart failure and about his last study on the New England Journal of Medicine about the use of acetazolamide in heart failure. Wilfried Mullens is a name in the heart failure topics. He is in the European Society of Cardiology, is professor at Assault University, and I thank you very much, Wilfried, to be here with us. Thank you.
Oops. Good afternoon, everybody. Thanks for the invitation. So how to treat congestion and acute heart failure. You can interrupt me if something is unclear, of course, and I'll more than willing to share the slides with you afterwards if you would have any interest. So I'm a heart failure specialist. I sometimes think I should have been a nephrologist, but I think both subspecialties are frequently encountered at your emergency visits. We do a lot of research in my center. It's of course not only me. I was fortunate that I have a lot of young people working together with me over the last decade to do much of the research. I think when you see a patient in the emergency room, it's important to recognize that many of us underappreciate the risk that our heart failure patients actually have to die or to be hospitalized. The risk is 20% in ambulatory patients with heart failure at 2 years. And in patients that you see in your emergency room, the risk is 60% at 1 year, especially if you send your patients home with ongoing congestion. So treating congestion is really important to improve outcomes. This has been shown already more than 30 years ago by Greg Fonarow, who showed that a reduction in filling pressures on the left heart is more important than an improvement in cardiac output. And the same is true for the right side. These are data coming from Groningen in the Netherlands and ambulatory patients on the left. And on the right, you see data that I did when I was still in the Cleveland Clinic in the US in patients with acute heart failure. So the higher the central venous pressure, the worse the outcome of the patient is. So it's extremely important to discharge patients out ongoing congestion. Important also is that you recognize that chronic kidney disease, CKD, is very prevalent amongst heart failure patients. About 50% of the heart failure patients have CKD. And if they have CKD, this is associated with a doubling of risk for all-cause mortality. So it is important that we try to do our utmost best to lower down the decline in CKD. And we have 2 drugs that actually can do that on the long term. And these are ARNI, so Entresto, and SGLT2 inhibitors. So on the long run, it's extremely important that all of our heart failure patients and diabetic patients and CKD patients are treated with these agents. Now, if we go back to acute heart failure, because that's the topic of today, so we recommend within our guidelines that you should exclude persistent signs of congestion before you discharge a patient to home. Now, if you would ask yourself, how can you treat congestion? For example, what is easiest to excrete from your body? Is it water or is it an isotonic solution? So meaning water plus sodium. Most of you might think it's isotonic solution, but that's not correct. It's very easy for our bodies to get rid of water, because if you drink 1 liter of water, already after 20 minutes, you're gonna go to the toilet. But if you drink water with some saline, with some sodium in it, it's very difficult to get rid of that. The reason for that is that if you drink only water, you change your osmolarity, and then your brain will swell, and your body doesn't tolerate that, so you go to the toilet very rapidly. But if you also eat sodium, you're going to have RAS activation, And RAS activation will actually retain all the water and the sodium a lot more than just water. There's only one exception to the rule. So if you have acute heart failure, those patients also have a very high ADH secretion or AVP. ADH is a hormone that you will excrete once your plasma oncotic pressure is above 280. But if you have acute heart failure, by the influence of angiotensin, you'll have more ADH for any level of oncotic pressure. That means that a patient with acute heart failure will have a lot of ADH, therefore will retain also a lot of water. But for chronic heart failure, water retention is less important. Now, if you eat sodium, what is going to happen? Well, importantly, all the sodium will be absorbed in your gut. You cannot lose sodium in your stool. So if you absorb all that sodium in your gut, eventually that sodium will be present in your bodies. And you might think, you know, if I eat every day a piece of pizza with a lot of sodium, well, then I'm going to excrete more sodium in my urine. And that's actually correct. So you see here, if you eat every day a little bit extra sodium, you will excrete more. Less is excreted with patients with heart failure, but all the patients, including normal human beings, will have a positive sodium balance. So that means that if you would eat every day a slice of pizza, within 1 week, you will have more sodium in your bodies than what you would have today. And that might come as a surprise for many of you. It means that heart failure doesn't only stop with the kidney, but it starts with the kidney. And if I would have more sodium in my body next week than today, that means that there are stores where I can put the sodium without affecting volume. And these stores actually exist. We've shown that you have sodium stores in your body, in your skin, in your bone, and in your cartilage. And these stores can actually maintain a lot of sodium without attracting water. Now, if you go back to the kidney is a very important organ. And if you look at the kidney has a GFR of 100 mL per minute. So that means that a normal kidney will filter around 1 kilogram of sodium every day. 1 kilogram. That's a tremendous amount of sodium which is filtered daily by your kidney. If you have a poor kidney function and your GFR is 10 mL per minute, you still will filter about 150 grams of sodium per day. So that means that the kidney, the filtration is not the problem, because most human beings, also in Italy, eat around 4 to 5 grams of sodium per day. It means that even if you have a very poor GFR, you're still able to filter enough sodium to get rid of that sodium daily. So the filter is not the problem, but it's the reabsorption. And if you look at the kidney is a very long tubule, and there is blood coming to the kidney via an afferent arteriole. And then you have capillaries, that's where the filtration occurs. And then the blood leaves the glomerulus via an efferent arteriole. And then again, you have capillaries running next to the tubules. So the kidney is in a unique organ which has 2 capillary networks in series lining next to the tubules. Now, stay with me for 5 minutes now because it's going to get a little bit more complicated. What happens at the glomerulus? Well, in the glomerulus, you see filtration. What you will filter is water, sodium, and toxic substances. And the kidney only wants to do one thing. It wants to maintain a GFR of 100 mL per minute. If you have heart failure, you'll have a reduced renal blood flow and an increased central venous pressure. Therefore, you will have a reduced GFR. But the kidney doesn't want that So the kidney will squeeze the efferent arterial side and will have vasodilatation on the afferent side in order to sustain a GFR of 100 mL per minute. Now, if you have a GFR of 100 at a reduced renal blood flow, that will lead to an increased filtration fraction, because filtration fraction is the ratio of GFR divided by renal blood flow. So if my GFR remains 100, but my renal blood flow is reduced, I have an increased filtration fraction. In other words, more of the water and sodium which is brought to the kidney will be filtered here in relation compared to the normal situation. That will also determine the content of water and proteins which leaves the glomerulus. And there will be a higher concentration of proteins in the blood leaving the glomerulus in heart failure patients. So if I have a higher oncotic pressure in the blood leaving the glomerulus in heart failure, that is the essence of heart failure. Because the oncotic pressure in the blood leaving the glomerulus will determine the amount of water and sodium uptake which is going to happen at the proximal tubular level. The higher the oncotic pressure here, the more water and sodium will be reabsorbed in the proximal parts of the kidney. And that is, dear colleagues, the essence of heart failure, of hypertension, and of chronic kidney disease. All these diseases are leading to an increased sodium reabsorption in the proximal parts of the kidney. If you go a little bit more distal at the loop of Henle, you'll have a sensor there which is called the macula densa. And the macula densa senses the amount of chloride which is present in the tubular lumen. Now, if I have heart failure and if I have absorbed more sodium and chloride in the proximal parts, there will be less chloride at the macula densa level. If the macula densa senses less chloride, it will release renin. And renin is not a good hormone to have if you have heart failure. So just because you reabsorb more chloride proximal, you'll have less chloride here and more renin secretion. If you then give loop diuretics block the uptake of chloride at the macula densa level. So they fool the kidney. If you would infuse yourself with loop diuretics, you'll have a renin increase immediately. So loop diuretics might not be the best solution for patients with heart failure because they work too distal from the site where most sodium is reabsorbed, and they block chloride uptake, therefore leading to more renin secretion. At the distal level, you'll have two hormones, which is aldosterone and BNP. Both of these hormones are increased in heart failure, promoting further sodium and water retention at the distal parts of the kidney. So eventually, if you have heart failure, you'll have an increase in plasma volume, and the higher the plasma volume, the higher the likelihood will be that your patient will die or be re-hospitalized with heart failure. And what to do then? Well, then we give these patients loop diuretics. Loop diuretics are the only class 1 recommended therapy for acute heart failure to treat congestion, independent of ejection fraction. They have a class 1 recommendation in HFrEF, in HFmrEF, and in HFpEF. Class 1 means you should do this. However, the data supporting the utilization of loop diuretics is pretty scarce, because the only trial that actually examined loop diuretics is the dose trial. It compared a high dose versus a low dose, continuous versus bolus infusion. And if you look at the endpoint, half of the patients included in dose was either dead or re-hospitalized after 2 months. And if you look at the endpoint freedom from congestion, only 15%, so 1 out of 6 of the patients included in this dose trial was actually dry at the end of the study period. There are many reasons why loop diuretics fail to induce decongestion. Like I explained to you, they increase neurohormonal stimulation, and none of our patients will have a normal diuretic response. Because if you would infuse yourself, if you don't have heart failure and you're not on loop diuretics yet, with 40 milligrams of furosemide, you should be peeing out 3 liters of water. But almost none of our heart failure patients is actually doing that. Another problem if you give loop diuretics in monotherapy is that if you give 3 consecutive days of loop diuretic therapy, you might excrete 1 liter of water every day, but the sodium content is actually dropping. So the first day you'll have a lot of sodium in your urine, but the second day there will be less, and even the third day there will be almost no sodium anymore in the urine. So the quality of the urine is dramatically dropping over consecutive days of monotherapy of only loop diuretics. So the problem is that loop diuretics work distal from the site where most sodium is reabsorbed. We wrote a document which I strongly encourage you to read, because the document has been downloaded more than 250,000 times, and it provides you with an algorithm how to use loop diuretics better. What do we tell in the algorithm? Well, if you give loop diuretics, you have to, the first thing is give the right dose. And if your patient is loop diuretic naive, so he's not on loop diuretics, we suggest you give 40 milligrams of furosemide IV bolus. If your patient is already on 40 milligrams of furosemide at home, we suggest you give double the amount bolus. You see the patient and you give it immediately as you see the patient in the emergency room. There is no need to wait for any lab test, just give it straight away. Then very importantly, you have to evaluate the effect of the loop diuretic. Loop diuretics work for 6 hours, so you should not wait until the next morning to evaluate the diuretic effect, but you should evaluate the effect directly within hours after you gave the diuretic. How to evaluate the diuretic effect? We give you 2 options. Either you measure urinary output, which should be at least 100 cc's per hour. Measuring urinary output is really difficult unless the patient has a Foley catheter, because patients pee everywhere, but not in the bucket that the nurse gives them. So that's why we suggest that you measure urinary sodium content. Take the sample of the urine that the patient makes, send it to the lab, and measure the sodium content. And that should be at least 70 megs per liter. If you don't reach the 70 megs, you will never get there, and you have to double the amount of loop diuretics already after 6 hours. That means if I gave 80 milligrams of furosemide now, and my patient doesn't reach my targets, I will give him 160 milligrams after 6 hours. In contrast, if my patient reaches the 70 megs, I'll give the same amount of loop diuretics every 12 hours. If you would use this scheme for loop diuretic therapy, you will reach a lot more patients being dry after a couple of days than not using this scheme. This has already been implemented now in our HFA guidelines to be used as an algorithm to improve the natriuretic response to loop diuretic therapy. We're testing this algorithm now in 4 prospective trials all over the world. Now, another problem that many of us are facing is that the renal function declines during treatment of acute heart failure. So worsening renal function, an increase in serum creatinine, or a drop in GFR when you're treating acute heart failure. What to do? Well, the first thing to do is to assess the diuretic response. Because if my diuretic response is good, that means I have a urinary sodium content of more than 70 mg per liter, I don't care. I don't look anymore at the worsening renal function. This is called pseudo worsening renal function, and you just continue your decongestive therapy. That's a very important message. If your creatinine goes up, but your patient is responding well to the diuretic therapy and he's still volume overloaded, you just continue. However, if my patient has a poor diuretic response, I have to rule out signs of hyperperfusion. Hyperperfusion meaning shock. This is extremely rare, but if it happens, these patients need inotropic support or mechanical circulatory support. More often, I don't have hyperperfusion, I just have to increase the diuretic intensity and I might have to add vasodilators. Why vasodilators? Well, this is a normal heart. A normal heart here is preload, this is afterload, and this is stroke volume. A normal heart is preload dependent. So if you would give a vasodilator to a patient with a normal heart, they will have a reduction in blood pressure because you will reduce preload. A patient with a failing HFrEF ventricle, so heart failure with reduced ejection fraction, they are not preload dependent, but they are afterload dependent. So if you then give a vasodilator, you can reduce afterload, therefore you will increase stroke volume. So the reduction in blood pressure, because the reduction in systemic vascular resistance, is overcome by an improvement in cardiac output. And these patients respond really well to vasodilators. Which is the vasodilator of choice? It's nitroprusside. Nitroprusside is a very old vasodilator, which will give you vasodilatation on the arterial and on the venous side, and it will help you to decongest these patients a lot easier. We give it titrated to a mean arterial pressure of 60 to 70 by trained nursing staff. It's a fantastic drug, and it will bail you out many times if you're faced with a patient with HFrEF who's not responding well to diuretic therapy. Now, what are the other diuretic options except furosemide or bumetanide? Well, you might think of thiazides. Thiazides, they work distal from loop diuretics, and they might be very effective because they might counterbalance the hypertrophy that you see with chronic utilization of high-dose loop diuretics. However, bear in mind that you should stop these agents once your patient is dry, because they have been linked with an increased risk for mortality if you give them long-term. The reason for that is that thiazides give a lot of hypochloremia. This is the chlorotic trial, and chlorotic was a Spanish trial that tested the addition of 25 milligrams of hydrochlorothiazide in acute heart failure. And if you look at the results, almost 50% of the patients treated with thiazides had a significant hypokalemia during the treatment phase. So thiazides are not an undangerous agents to use, and you should monitor potassium levels very closely. Can you use high-dose spironolactone to help you decongest patients better? This has been tested in the Athena trial. Athena compared a low dose, 25 milligrams, versus a high dose, 100 milligrams. It did not show to be of any benefit to get more patients dry. This does not mean that spironolactone is not an important agent. You should give it to everybody with heart failure, but it will not help you to decongest patients better if you give a higher dose. So 25 milligrams is enough. Because thiazides and loop diuretics and MRAs work distal from the site where most sodium is reabsorbed, we should focus our attention to the proximal parts of the kidney. Because like I explained previously, almost 70% of the sodium is reabsorbed in the proximal parts of the kidney. And that is why we tested already more than a decade ago, or we had an intention to test acetazolamide. Acetazolamide is a very old diuretic agent been used for more than 70 years. It blocks carbon anhydrase in the proximal parts of the kidney, and therefore it interferes with the sodium proton exchanger, which is responsible for 60% of the sodium uptake in the proximal parts of the kidney. We did a pivotal trial in 2015 where we showed that if you combine acetazolamide with furosemide, you can double the amount of sodium excretion. Double, eh? This is spectacular. You can get double as much sodium out if you combine it. And that was the reasoning to do the AT4 trial. AT4 was a large trial. It was a multi-center, prospective, double-blind, placebo-controlled trial run in Belgium in 29 centers. And it was a very pragmatic trial. What did we do? We compared 3 days of high-dose, standardized IV loop diuretic therapy plus placebo versus the same amount of loop diuretic therapy plus once daily 500 milligrams of acetazolamide IV bolus. So very simple. 2 times IV loop diuretics for 3 days plus placebo versus the same amount of loop diuretics plus 500 milligrams of acetazolamide IV once daily bolus. The primary endpoint of the trial was, is your patient dry after 3 days of decongestive therapy? What is dry? Well, we learned the investigators to fill in this congestion score. And it was composed of, is there edema on the legs? Is there pleural effusion? And is there ascites? If there was no edema, if there was no pleural effusion and no ascites, the patient was deemed to be dry. If there was edema, ascites, or pleural effusion, the patient was deemed to be wet. These are the baseline characteristics of the patient groups. When you look at the patient groups, these are elderly people. And we are really proud on that because this is a pragmatic trial. We wanted to include patients that you and I see daily in the emergency room. And what we're seeing in Belgium, but I'm 100% sure it's the same in Italy, are elderly, frail people, 78 years of age, with very high NT-proBNPs of 6,000 and a lot of comorbidities. The mean GFR was 38. This is absolutely reflective of what we wanted to do. We wanted to develop a trial which would include patients that you and I see on a daily clinical basis. These patients were really wet. They all had significant edema on the legs, 60% had pleural effusion, and 10% also had ascites. When we compared ourselves with the other diuretic trials which I talked about, our patients were significantly older, were more treated with spironolactone, and had higher NT-proBNPs. This was our primary endpoint. It was, is your patient dry after 3 days of consecutive diuretic therapy? In the placebo group, it was 30%. In the group that received the same amount of furosemide plus acetazolamide, it was 42%. Number needed to treat of only 8, risk reduction of 46%. Impressive. When you looked at the forest plots, there was a clear trend towards benefit of acetazolamide in all the subgroups that were pre-specified. Old, young, higher or lower ejection fraction, it did not matter. The drug was equally effective across all pre-specified subgroups. Now, I can hear many of you think, I don't know acetazolamide, I don't use it, I don't need it, is what many of you will think, because I use something differently. That is why we predefined that we also would collect the decongestion rates at discharge. In the placebo group, it was 62%. It means that 62% of the patients that were treated without 3 days of acetazolamide initially were dry at the moment of discharge. At day 4, 5, 6, investigators could add acetazolamide if they wanted, because then they could do whatever they want. In the acetazolamide treated group, it was almost 80%, and this is really, really important. This means that you cannot make up for not using acetazolamide the first 3 days. Number needed to treat of only 6. That's really low. P-value 0.0001. The reason for that is that we saw an incremental benefit the first 3 days of giving acetazolamide. We prevented loop diuretic resistance from occurring by adding acetazolamide. And if you give loop diuretic therapy in monotherapy, you have so much loop diuretic resistance that you cannot overcome this anymore after 3 days without giving acetazolamide. We clearly showed a spectacular increase in natriuresis, and this all led to a reduction in length of stay in the acetazolamide treated patients. You might think, is it safe to give this drug to the patients? Well, the answer definitely is yes. There was no increase in any of the pre-specified renal endpoints. There was no increase in metabolic acidosis. There was no increase in hypokalemia or hypotension. It's absolutely safe to add this drug to furosemide or bumetanide. Now, the question, of course, is, can you also give an SGLT2 inhibitor, or are SGLT2 inhibitors equally effective to decongest? Well, the answer probably is no, because SGLT2s do not interfere with sodium uptake at the proximal parts of the kidney. SGLT2 inhibitors do increase diuresis by increasing an osmotic diuresis, but they do not increase natriuresis. So SGLT2s are really important agents for the long run to improve outcomes, but they will not help you to increase natriuresis like acetazolamide does. I must say that we're really proud that we were able to publish this pragmatic trial in the New England Journal of Medicine. These are 6 of my co-authors, and all of them have been PhD students in my center. So it is possible to publish in the New England Journal of Medicine, even if you're a PhD student. Some interesting sub-analysis. The drug was equally effective across the board of ejection fraction. If your ejection fraction was 30 or 60%, it did not matter. The drug was equally effective. The drug really helps you to prevent loop diuretic resistance. This is a sub-analysis which is going to be published in the European Heart Journal very soon, where we actually prove that the drug is really helping to prevent loop diuretic resistance. Another important sub-analysis will be published in the Journal of American College of Cardiology, where we show that the drug improves natriuresis, and this natriuresis is linked to an improved outcome. So we think it's time for a new paradigm, which is door to diuretic time, door to combo diuretic time, a combination of loop diuretics plus once daily acetazolamide. These are the current guidelines of ESC with regards to diuretic therapy. Loop diuretics have a class 1C recommendation and thiazides a 2A recommendation. Acetazolamide is not in the guidelines yet, and it will take up to 2026 before we will publish new guidelines, but we feel that acetazolamide might have a recommendation like this. It's recommended for patients with acute heart failure with signs of fluid overload who were previously treated with oral loop diuretics to improve the incidence of decongestion. It's not in the guidelines, of course. This is just hypothetical, but we think it might be a 2A or a class 1 recommendation, depending on what evidence we have at that moment in time. So how do I look at treatment of congestion? This is the way I do it. This is the way I think you should be doing it. In acute heart failure, the first days, loop diuretics based on natriuresis guiding together with acetazolamide. Once your patient is dry, you switch them to oral loop diuretics. You try to give them the lowest amount of loop there is possible. You add an SCI2 inhibitor at day 2 or 3 to improve long-term outcomes, and you continue and you try to up-titrate neurohormonal blockers to improve outcomes on the long run. I'm going to stop here, but I'm open for any question you might still have.
Thank you so much, Wilfried, for the brilliant presentation. I asked to, is there any question? I start to do some questions because I would have hundreds of questions, but I start with a few of them. The first one is you choose to as your primary outcome the congestion. That is something important, of course, in heart failure. We have seen all these data, but why didn't you choose a harder outcome? Because it's less prevalent.
Yeah,
for example.
That's it. So it's a very good comment. So I would rather have chosen heart failure rehospitalization and all-cause mortality as a primary endpoint, but then I would need it for 4,000 patients, which is just impossible. You know, this is a pragmatic trial. We needed about 2.5 million euros to do the trial, and there is absolutely zero interest of any company to sponsor such a trial. So we went to the Belgium healthcare authorities and they gave us the money, but there isn't any company which would give you 40 or 50 million euros to do a trial like that. And we have to bear in mind that we're looking at very elderly, frail people here who come into our hospitals, and I guess the same in Milano, with one complaint, you know, I would like to get rid of all this volume because I'm suffocating, my legs are swelling, and we don't have any therapy which is proven to be safe and effective to do that. And I think this is now the first time ever that we have a combination of drugs that can do that in a safe, easy manner at a very cheap cost. So I agree with your comment. It would have been even better to show hard outcomes, but with the 500 patient trial, you cannot show that. Also with a drug that only works for a couple of days, of course, and because we only gave the drug for 3 days.
I suppose that your answer would be this.
Yeah.
But I think that a very important thing is
Yeah,
that
absolutely. Yeah.
This trial is absolutely without any sponsorship from industry, and this is very important, I think, and very good. Is there any other question? Okay. Someone? Yes, Marco Paganuzzi.
I think you're on mute, Marco.
My bad, sorry.
No problem.
Could have been better. So thank you for the lesson and complaints for your trial. Following what just Giorgio asked you, I wanted to ask you if you consider the results from your trial and your endpoint enough to give a clear indication for the use of acetazolamide. I think you already answered this question a little bit in your explanation, but or you feel that further RCTs with harder outcomes, even though they are harder to be made, are still needed. Maybe to put acetazolamide in our clinical practice routine, or you think it's enough already?
Of course, Marco, I'm biased, but I think the reason why the New England accepted the trial is because they also feel that this should be a drug that everybody should be using. I mean, we're actually aiming at a patient population for which we almost don't have any solutions. If you look at the number of patients who are discharged from hospitals with ongoing congestion, it goes up to 60 to 70% on all the registries. It's because we don't have an easy solution to treat the problem. And yes, I agreed to you and with Giorgio that if we would have shown heart failure heart outcomes to be improved as well, it would even be better. But let me question, let me repose a question to you. Why would you not use it? It's safe, it's cheap, it's easy to use, and it's really effective to treat the #1 complaint that your patients are having. And it's the first time we have such an agent like that. But I get the comment, of course, but I think that the reason why they took it is because they too feel that this is an important breakthrough in a domain for which we almost are lacking therapies. And I think to answer the question also, again, with reduction in heart failure hospitalization, there hasn't been a single trial with a short-term acting agent or an agent that you give for 3 or 4 days that has ever shown to improve outcomes in the long run. And the reason for that is that there are so many confounding variables. Some people give an ACE afterwards, some don't give an ACE, some people give an MRA. Sometimes the patients are discharged and they go to the McDonald's every day, they don't take their medication. The only thing that we know is the disease-modifying agents that you give chronically, they improve outcomes. But this is just a diuretic trial, and a diuretic trial should focus basically on decongestion. And of course, I would have hoped that there was a trend towards better outcomes, but we didn't show that. So if somebody would give us, let's say, 30 or 40 million euros, I'm more than willing to do the trial on a larger scale, but I don't think that will ever happen. But I get the question, it's something that everybody asks, but for me, and I think for many people, I mean, why do you give furosemide? Why do we give bumetanide to everybody? The data are even less solid than what we have now. Now at least we have the combination works better than giving it monotherapy. So why not use it?
Can I ask another question, Giorgio?
Of course you
Yeah,
can.
go ahead.
So another question is one of the main points I think of your trial is the randomization, which is such a very strong one, and both population looks like really comparable. So the question is, how hard was that to achieve, and was something which gave you big issues or not at all?
Yeah, I mean, the reason why the trial was published is because I think the design was really good. If we wouldn't have randomized double blind, it would never have had any impact, of course, because then there was absolutely zero potential for bias. Why we achieved that the groups were homogeneous is just because the inclusion criteria were pretty strict, and we also stratified according to ejection fraction. And so the only stratification that we ask is with regards to ejection fraction. And then in every center, we also did like a randomization. So it was impossible. So the trial was basically randomized per center also. So there were 29 centers. And in that way, we ensured that in every center, we had the same amount of patients included the acetazolamide arm to have REV and have PEV. Because if we wouldn't have done that, there might have been discrepancies or differences amongst the two groups. So you have to basically randomize all over in the entire trial, but also per center. And then we stratified according to ejection fraction. And then there were, just like there were no baseline differences amongst the patients. So doing the randomization was not the hardest part, just to motivate the sites to keep on randomizing. That was the problem. And so doing a trial in acute heart failure is really complicated. It's 10 times easier to do it in chronic heart failure than in acute heart failure. And you know that because you all work in emergency rooms. Patients come in, they don't come in between 9 and 5. They come in at 5:30, at 1 a.m., or they come in at 10 a.m. while you're busy and you don't have the time to call a research nurse. Once the research nurse is called, somebody has already given another therapy. The patient is transferred from the emergency room to a general floor. So it's extremely difficult to do a trial in acute heart failure in the emergency room. So many sites said, you know, we're only going to include patients on Mondays and Tuesdays because they needed to collect 3 days of data at least. So it was really difficult to get inclusions done. And we were planning to do the trial in 2 years. Eventually it took us 3 years, but that was because of COVID. Because during COVID, we also had COVID during the trial. So there was 0 inclusions during the COVID periods. So it was a huge endeavor to do it. From outside, it appeared to be a very simple trial, but doing it was a hard time. Yeah. And if you would ever like to do a trial like that, you have to be patient and you have to be courageous and you have to call your sites almost on a monthly basis. And people already knew when I was calling them, yeah, we know we have to include a patient, and then they included the patient a couple of days later. So it's not easy to do an acute heart failure.
Stefano Nattino, that is Elisa Lepori.
Okay.
Yeah, hi, thank you for your lesson. I just had 2 questions, very practical. If there is a lot, if the acetazolamide causes a lot of hypotension, and because I know in some centers when there is no response like to furosemide, maybe they switch to torazemide or etacranic acid or another, to another loop diuretic. Is do you know, in your experience, if the association with these agents is comparable, or if there is if you have any comment on this?
Yeah, you will not see hypotension. We never ever see hypotension. I would not be afraid of hypotension if you use it in combination with furosemide or bumetanide. So that's really not a problem. You only see hypotension if your patient is really if your patient is dry, of course, but if your patient is wet, you will never see hypotension. You shouldn't be afraid of that. No.
And about torazemide and etacranic acid?
Well, toracemide, of course, that's a thiazide-like agent. So there has been one trial now with a comparable agent, which is hydrochlorothiazide in the chlorotic trial. What they showed is that if they use a combination of a thiazide plus furosemide versus furosemide monotherapy, that they have a little bit more weight loss, but they also did not report more blood pressure reduction. So I don't think blood pressure reduction is such a big problem with diuretics, unless your patient is too dry, of course. But once he's not really dry, still wet, it's okay to use the combination. But again, I would prefer to use the combination of acetazolamide plus furosemide. Thiazides are dangerous agents. So even in trial settings, they cause a lot of hypokalemia, which is really dangerous. And if you would use a thiazide, use it temporarily for a couple of days until your patient is dry, and then stop it again, because if you give it on the long term, many of them have hypokalemia and hyponatremia, which is linked to worse outcomes.
There is Fabrizio Turrini and then Massimo Salvetti. A lot of questions. When you want to go away.
Oh, it's fine. It's fine. Go ahead.
Fabrizio from Modena. Really congratulations for your presentation and for your work. I have a couple of small questions. The first one is about, I think if we want to target the congestion, it's time to improve our tool to measure it. I think it's time to set up a trial in which we try to test what is the best tool for measuring the congestion, and maybe we can join our forces to do that.
Yeah.
And the second question is, what do you think about the evaluation of intravascular congestion by renal venous Doppler ultrasound? I know you made some work about that, and I tried a little experience, and I found it very, very interesting.
Yeah, very good question, very difficult answer. So in the short answer is I give diuretics to get rid of extravascular volume overload. So what I then measure is edema, is pleural effusion and ascites, and that's also what we did in the ADFOR trial. So we just give, that's the reason why I give diuretics. I don't give diuretics to a patient who does not have extravascular volume overload, but only an increase in pressures. So I think that's a major difference. But congestion, what you're alluding to, that's a hemodynamic problem of increased filling pressures. And many patients have congestion without a lot of volume overload. If you, for example, have PEF, and you're stable, and then you develop atrial fibrillation, you develop high pressures, you get pulmonary edema, we give a little bit of diuretics, but we treat the congestion more with other drugs than diuretics. So to measure congestion, I think it's a combination of technical and clinical exams. And what you're alluding to, I think echo is really useful to measure the pressure in the heart at the vena cava, also at the level of the hepatic veins and then the renal veins. The renal veins, we do it for research. We don't do it clinically because it's really, I still think it's difficult to do it. Although I do it on a daily basis, I still find it difficult. And it's also, I need a different echo probe. So a combination in the future might be the ideal scenario, but you always have to think, you know, most physicians who are seeing patients with congestion don't have the tools that you're just referring to. They just have their eyes. They might have an echo to have a quick look and a chest x-ray. And I think we need to help them as well. So there is also a lot of development in the biomarkers. So currently I would more or less stick to a combination of echo and clinical exam, but bear in mind that the treatment of congestion is not always diuretics. And the second question you were referring to was about, wait, remind me, the renal venous flow. Yeah, okay. So we use it more for research. Yeah.
Thank you very much.
No problem.
Massimo Salvetti.
Thank you very much for your very interesting presentation. My question is about the dose of the drug. How did you choose this dose, and do you think that it can be changed, tailored to the single patient?
We chose the dose because that was on the label of the drug. And so we started with our pivotal experiments, let's say a decade ago, with 500 milligrams, and there already we saw a doubling of the natriuresis. So that's why we just stick to 500 milligrams. It's also when if we would have chosen more, let's say 1,000 milligrams, we would not have had the allowance of our national government to do the trial, because on the label it states 500 milligrams. There's also many people ask me about the oral dose because we give it IV. And I think in Italy, you only have the oral dose available in many centers. Then we would use 250 milligrams because that's also on the label. And from experience, it also works if you give 250, but so orally, I mean, but the response is less predictable because if you have a lot of GI edema, the absorption of the drug might be less.
Thank you.
Another question, but in Belgium before your trial, was acetazolamide one of the standard treatment in heart failure? Because in Italy, I think that until now it is used only when there is a important metabolic alkalosis from.
Yeah, I know. I mean, but it's with all these old agents, and nobody uses old agents that still seem to work because there is no company sponsoring and no company is going to tell you. But I think there are so many good drugs available for many diseases that we just forgot about, which are from a physiological point of view really, really good drugs to be used. And I think I would all encourage you to investigate those drugs because I mean healthcare is just. The costs are going to the roof, and we need different strategies now to take care of the burden of disease which is coming at us.
Any other question? I would like to thank you for the presentation and for all the stimuli that you sent to us. Also, this letter one. So we need to think to everything that we already have, and not only to new drugs and new things and new tools. So I think that this is very, very important. And thank you so much for being here with us. And if you will come in Milan, you will be our host, and please tell us.
Okay, I'll do so.
We
Thank
will
you.
give you another 1,000 more question if you come in Milan. Okay.
Okay. Thank you.
so
All the best,
much.
Georgia, and to all
Thank you.
people there.
Thank you very
Bye-bye.
much. Thank you. Bye.
Thank you. Thank you.